We can't hear you. Probably you need to activate.
There? Do you hear me now?
Now it's fine. Go on. Thank you very much.
Thank you very much. Okay, so, first, some background. Septic shock difference with hypoglycemic or cardiogenic shock has these characteristics. Several pathogenic mechanisms change over time. For example, early on, there is a decrease in vascular tone and at least relative hypovolemia, leading to a fall in cardiac output, systemic blood flow, and mean arterial pressure, meaning perfusion pressure. This decreases, of course, microcirculatory flow. And in this early stage, there is still no endothelial dysfunction. It's only a vasomotor cytokine or mediator-induced phenomenon. And then if you restore cardiac output, increasing with fluids, or you restore mean arterial pressure with norepinephrine, then you will probably restore also microcirculatory flow, because in this early stage, there is a coupling, a hemodynamic coherence between macro and microcirculation. Unfortunately, in patients that evolve into severe septic shock, there is a progressive endothelial dysfunction, activation of coagulation, aggregation of leukocytes and red blood cells in the microcirculation, increased capillary leak, edema, venous congestion, etc. In this stage, there is a severe microcirculatory dysfunction, meaning that even if you increase systemic blood flow, pushing cardiac output and giving more and more fluids or vasoactive drugs, you will not restore the essentials, that is microcirculatory flow, and the patient will die in progressive hypoxia. In this stage, there is a loss of coherence or coupling between macro and micro, and the treatments should be quite different. If you insist in giving the therapies that are beneficial early on, maybe you could even worsen things. Having said that, let's go to, but keep in mind, please, this, to perfusion-related variables. Lactate has been the classic marker of hypoxia, tissue hypoxia. We were taught about this in the university, and this has been in the clinical mind for decades and decades, and this is probably the reason why the Surviving Sepsis campaign, even in the 2016 guidelines, proposed normalization of lactate as a proof or as a target of septic shock resuscitation, trying to resolve, of course, tissue hypoxia. However, and first, is this true? Is lactate representative of tissue hypoxia or hypoperfusion? Of course, yes, because when flow decreases at the tissue level, then the mitochondria very early on is blockade, suffers a blockade, a hibernation process, and it does not function. So all the generation of ATP, further generation of ATP at the cellular level, at the cell level, is produced by a dramatic increase in anaerobic glycolysis, which is a sort of auxiliary pump, where it generates huge amounts of ATP. It increases its activity around 1,000%, and then this maintains cell vitality for some time, but this produces a huge amounts of lactate as a waste product that is extruded to the extracellular space. So if you, in a setting of low flow, you see an increased lactate, it means that the cells are suffering and are using this aerobic glycolysis to survive. If you restore flow and lactate decreases, this is very good, because lactate enters the cell again and is normally metabolized. So in one sense, of course, in increasing lactate is hypoperfusion or hypoxia related. However, there are other important, very relevant causes of increased lactate, of an increase in lactate in acute circulatory dysfunction or in shock. One most relevant is adrenergic-driven muscle lactate production. Epinephrine, when it's increased, of course, in this setting, stimulates beta-2 receptors at the cell level, increasing glycogen lysis, and this produces huge amounts of pyruvate and lactate that is extruded, and lactate becomes a metabolic fuel for active muscles, also for the heart. You know that the heart consumes lactate during circulatory dysfunction, and is even considered an inotropic drug, and also the brain uses lactate. It's the fundamental metabolic fuel of shock, because these tissues, active muscle, the brain and the heart, by definition, are alive, and they are using oxygen. They have vital mitochondria. They use lactate. And we don't have glucose in this shock stage because by definition, the liver has a decreased flow or has a metabolic blockade, is not producing glucose. So this is why lactate is so fundamental. And this is why it is protected in this shuttle by epinephrine. But also we know that in shock states, liver blood flow is decreased and this is associated, of course, with the decreased lactate metabolism or clearance. We demonstrated this in this physiological study where slow lactate clearance, let's say, where this state was associated with the decrease in IgG-PDR, in disappearance of indocyanin green, which is a marker, indirect marker of liver flow, and also by an increased pCO2 at the gastric mucosa level by gastric tonometry, meaning that these slow lactate clearers were associated with a reduced hepatosplanchnic perfusion. But this is not the only reason, because in this experimental study with an endotoxic shock model in sheep, we demonstrated that when we applied here exogenous lactate clearance, meaning that we infused 1 millimole per liter per kilo of sodium lactate, and we took pharmacokinetic samples during half an hour every 2 minutes and draw a real lactate curve, a clearance curve. And we saw that in endotoxic animals, the lactate clearance compared to sham is decreased 1 hour after shock to 10% of the normal values. And since this model was resuscitated, we had restored mean arterial pressure with fluids and vasoactive drugs, and we put Dopplers and flow meters in the port and the hepatic artery, sorry. We saw that this was in the setting of preserved hepatic blood flow. So some metabolic blockade occurs, saving oxygen, not for metabolizing lactate in the Cori cycle, but for other functions that we don't know. But so, in other words, a persistent hyperlactatemia can be caused, of course, by residual and persistent hypoperfusion at some tissue level, but also by a strong adrenergic response at the muscle level, and also by abnormalities in liver flow or function. And this is quite important to try to establish the predominant cause of this hyperlactatemia, because if you consider that it is more hypoxia related, you should continue resuscitation, give a fluid, dobutamine, blah, blah, blah. But if not, you will induce harm if this is not related to hypoxia, and you should stop resuscitation. And this is very important because we know that morbidity and mortality in the critical ill in shock is caused by, in an important amount of patients, by over-resuscitation and fluid overload. When we derive from some of our studies the evolution of the lactate kinetics in survivors of septic shock, we see that lactate is increased and decreased very rapidly, probably in its hyperperfusion-related source, but then after 4 or 6 hours, even in survivor, it decreases more slowly because this is probably the metabolic residual lactate. Compared to that, I will speak about this later, other more flow sensitive parameters that normalize very fast, such as capillary refill time, delta pCO2 or SvO2, normalize very fast, and they are normal at 4 or 6 hours, when lactate in some patients is still abnormal. So they have, these variables have different kinetics. And of course, you have to keep in mind, and we already know this, as the speaker before said in cardiogenic shock, an increase, a persistent or worse, an increase in lactate over time instead of decreasing is associated with a very high risk of mortality, whatever the cause, refractory shock, toxic hyperadrenergia, severe microcirculatory dysfunction, liver dysfunction, whatever. But of course, it is very bad news. Some years ago, almost 10 years ago exactly, we published this opinion paper where we proposed that with the multimodal assessment of perfusion-related variables, you could try to figure out the probability that the lactate is more hypoxic or non-hypoxic related, with clinical therapeutic implications, of course. And this, we propose that we assess it in parallel with lactate, SvO2, delta pCO2, and peripheral perfusion. And if these 3 variables were normal, the probability that the lactate is hypoxia related is very low indeed. This is what we hypothesize. And if one of these is abnormal, we should consider this lactate as hypoxic unless it's proven otherwise. So this is with this proposal in mind. Let's just a couple of minutes. Why SvO2? SvO2 or mixed venous or central venous, it's physiologically very important signal because it's the balance between DO2 and VO2, the adequacy of DO2 compared to the requirements of oxygen at the tissue level. Of course, it's very important, and this is the reason why Rivers used this 20 years ago in this famous study where he demonstrated that the SvO2, a very low SvO2, was a reasonable target for septic shock resuscitation. However, it has some drawbacks. First, after Rivers, when we looked in the ICU, we will treat this low SvO2. We never found such a low values as in the emergency department in Rivers hypovolemic septic shock patient. It does not exist. And although another problem is that, of course, when you have a severe microcirculatory dysfunction, which usually is present in refractory shock, patients do not use oxygen in the microcirculation, do not extract oxygen. So patient can live with a normal or even supranormal SvO2 value, confounded, of course. And please have in mind that SvO2, which we use more at the clinical bedside, SvO2 is superior vena cava territory, meaning that this is the brain, and this is also the respiratory muscles, of course. And then when you intubate the patient and sedate the patient in emergency fashion, rapidly SvO2 goes up to 80 sometimes, but this does not mean that you have resolved systemic hypoperfusion because the inferior vena cava territory, the hepatosplenic region, can be very low in parallel to the normalization of the SvO2 territory, the superior vena cava. And even if you measure a mixed, you can have a mixture of the two, and you cannot detect that you have regional hypoperfusion. And we also demonstrated that in a cohort of 100 patients that were subjected to emergency intubation, in septic shock patients in this cohort, which were the half, the SvO2 increased from 61 to 68, 15 minutes after emergency intubation, meaning that sedation and intubation, by decreasing dramatically oxygen consumption in the superior vena cava territory, can increase per se, of course, SvO2, and then you cannot be sure that this is a cosmetic value or you resolve global hypoperfusion. And concerning the venous pCO2 gradient, this is a very important physiological parameter, of course, also, because as you know, this has an inverse relationship with cardiac output. It's not perfect, it's this shape. And why? Because in septic shock states, at least, or in low flows, let's say, the aerobic produced pCO2 at the cellular level diffuses to the microcirculation, but when flow decreases, it's got the phenomena named as stagnation, and the CO2 is stagnated in the microcirculation, and then when the vein return to the heart or to the lungs, they are more saturated in CO2. So this is why the delta CO2 increases. So when the low flow starts to decrease at the tissue level, there is station in increasing the CO2 in the venous side, of course. This increases the pCO2 gradient. At some point, of course, when the massive CO2 production is induced by real hypoxia and tamponade of protons by bicarbonate, massive CO2 production, then the delta explodes and then goes fast. And also, but more clearly, you can detect this having sensors of CO2 at the tissue level, as we had in the past with gastric tonometry. And of course, the ratio between the venous arterial CO2 difference and the arterial venous O2 difference, this has been proposed as a marker of tissue hypoxia, and this nice editorial that we wrote some time ago explains the mechanisms, I think, very nicely. So we also demonstrated that a persistent delta pCO2 is associated with bad prognosis when it's associated with persistent hyperlactatemia. So and putting this in context, in this study, we performed multimodal perfusion assessment in a cohort of shock resuscitated very early on. And after 1 year and a half, we picked up only survivors. And we compared the behavior of the kinetics of recovery of different perfusion-related variables in these survivors. The columns represent persistent abnormality of each parameter. And you see that in the survivors at 24 hours, 50% of the patients had a persistent abnormal lactate. So if you pursue normalization of lactate, you should continue, by definition, resuscitating, giving fluids, vasoactive, blah, blah, blah. However, in the same survivors, at 2 hours, almost 85% patients had normalized SvO2, pCO2 gradient, CRT, and SvO2 by NIRS. So these are more flow-sensitive parameters. They respond faster to resuscitation. So this is very interesting, you know, because if you stop resuscitation by CRT, for example, you stop earlier than if you stop resuscitation with normal lactate. They are not equivalent. You have to take this in mind. And we also try to support this in this retrospective study where we compare it in our database, patients with, let's say, according to our proposed classification, with hypoxic lactate. There were 70 patients, versus 20 with non-hypoxic lactate. They, at baseline, they had the same lactate of 4. And you see that the black columns represent the hypoxic lactate according to this proposal. And you see this is not statistically significant, but it shows trends that patients with black columns tend to have a worse prognosis. But the final words is about peripheral perfusion. This should also be considered part of the hemodynamic monitoring, because as Max Harry-Wild said very early in '69, the temperature of the grade 2 is as a strong prognostic value, has as a strong prognostic value as lactate in septic shock, in general. And why is this? Why the skin is so relevant? Because the skin has a strict and exclusive sympathetic control. It has no autoregulation, no metabolic control compared to other territories that are more complex. So if systemic blood flow decreases, if perfusion pressure decreases, the skin immediately becomes vasoconstricted because of low flow, and also because of the adrenergic tone. So the skin behavior during resuscitation represents adrenergic tone. For one sense, if you restore flow, adrenergic tone decreases, but it also represents a very interesting, let's say, signal. It's ischemia reperfusion. If you have a cold, clammy skin, and then you increase cardiac output and you increase mean arterial pressure, and then the skin recovers its warm, mottling disappears, capillary refill time normalizes. This is ischemia reperfusion at the bedside, costless, universal. You can do this in the sub-Saharan countries and also in the Mayo Clinic. It's for free. And also microcirculation. So it's very important, and consistent with that, several, let's say, epidemiological studies have shown that if observational, including one of our groups and Jan Bakkers, if you normalize peripheral perfusion early after a couple of hours of resuscitation, even in the emergency department or in the ICU, you have a risk of mortality less than 20%, probably represented patients in hemodynamic coherence, patients that respond fast, they have preserved microcirculation, etc. And if you do not, it probably represents a more severe cohort of patients where they lost already hemodynamic coherence and they die more than 40%. This is very consistent. And as I said before, CRT is the first variable in normalizing survivors of septic shock compared to others. And also the behavior of peripheral perfusion or the dynamics of recovery goes in parallel with the flow as assessed by pulsatility index in the hepatosplanchnic region, meaning that if you normalize the skin, you have good probabilities of normalizing the hepatosplanchnic region. The inverse is true, sadly. If you don't normalize the skin, the probabilities of normalizing the hepatosplanchnic region, because the neurohumoral compensatory response is similar, let's say, you have nil possibilities of that one. So this is the reason why, and I will finish shortly, why we thought about CRT on assessed in a standardized way as a target for septic shock resuscitation, considering all the aspects as I mentioned before. And this is why we performed the Andromeda study, the #1 study in JAMA, published in 2019, where we compared the resuscitation strategy aimed at normalizing lactate or compared to normalizing capillary refill time. As you know, we have found in this randomized control trial 8.5 decrease in mortality, lower mortality in the CRT group, almost reached classical statistical significance, but very important from a clinical point of view, 8.5 difference. And this was confirmed by a Bayesian analysis published 1 year after in the Blue Journal. and less organ dysfunction, less intervention, because resuscitation could, of course, be stopped earlier than with lactate. A series of post hoc studies have tried to figure out the mechanism behind this, including this one. This is a physiologist where we demonstrated that the normal capillary refill time after resuscitation is associated with normal microcirculation, normal hypoxia variables such as the ScvO2 ratio or lactate pyruvate, and normal regional blood flow. So capillary refill time then, for this reason, has been incorporated in the last sepsis surviving campaign guidelines, and will be the basis of our ongoing, and we will start in March, a worldwide study with 20 countries, the Andromeda Shock 2 study, where we will compare a CRT targeted and hemodynamic phenotype guided resuscitation strategy compared to usual care as a way to further decrease mortality. This is my final slide. How to, and we proposed this recently. If you have a persistent elevated lactate, you have first to rule out that there are causes not related to the circulatory dysfunction, explaining this. But if these are ruled out and you have a persistent lactate, you look in a multimodal assessment, as I said before, with SvO2 and peripheral perfusion. They are normal. Of course, you suspect this is hypoxic lactate, you increase flow, and then if it decreased lactate, you are okay. But if you have normal SvO2 and normal peripheral perfusion, to be sure, you can see the delta pCO2. The delta pCO2 is more than 6, then this means, according to Jean-Louis Teboul, and we agree, if you have a prolonged delta pCO2 in this setting, you have space for acting on cardiac output, to act on systemic blood flow, and you should try that one. But if you have a normal pCO2, it's bad news, because probably you will have no space for increasing systemic flow, and then you should probably reassess everything. Thank you very much.